Hello, and welcome to the Physical Therapy Owners Club podcast. I am Nathan Shields, and today I've got a returning guest, Bart McDonald, the crazy guy from Idaho. Bart, thanks for joining me again, man.
Absolutely, Nathan. So fun to be a part of this. This is really a cool thing for physical therapists to be able to, I think, just glean from each other what's going on and how to improve practice of physical therapy.
Right. Again, that's the whole reason why I'm doing it. I love having successful PT owners like you on. For those who didn't capture my episode with Bart probably 4, 5, maybe 6 months ago, Bart McDonald is CEO and founder of Superior Physical Therapy and Diagnostics in Idaho, has multiple clinics. The previous episode that we did, we talked about his book that he had recently written called Debt Free PT, and how to help PTs get out from underneath the burden of student debt, how owners can help those new grads who are underneath a heavy student debt load. And so you can listen to that and glean some information on how to really help our new grads get out from under the student loan burden that they have, and how we can incentivize them and talk to them and recruit them as well.
Yeah.
But today we're talking about something different because those who have followed the podcast know that I've done diagnostics and I do diagnostics. I'm board certified in electromyography. I have my ECS. I've also learned how to work musculoskeletal ultrasound, although I'm not fellowship trained and don't have my certificate in it. Nonetheless, I know plenty of owners that do across the country. And Bart is one of the owners that I know through our hands-on diagnostics network that has been really successful with the implementation of musculoskeletal ultrasound in his practices. So I wanted to highlight him today and talk about musculoskeletal ultrasound because I think he feels like I do, that musculoskeletal ultrasound should be in a majority of outpatient orthopedic clinics across the country. It should be a widely used tool for the benefit of physical therapists in general, and a benefit and an add to the care that we can provide based on the diagnostics that we can do within our scope of practice. And correct me if I'm wrong, Bart, I think most states allow for physical therapists to do diagnostic ultrasound.
That's my understanding. When we first got into it, I looked at our Practice Act, and I think that's where everybody should go, right? Yeah. I was looking at EMG, and in the state of Idaho, we have a great solid Practice Act for us being able to do nerve conduction studies in EMG. And then we looked at ultrasound. I mean, ultrasound was all over our Practice Act. It talked about using acoustic energy, both for the treatment and or benefit of the patient. Really, diagnostic ultrasound has been around since the 50s, but as technology has improved, it's much, much better. And so who knows exactly what those folks, when they were talking about acoustic energy, were all really thinking about when they put the Idaho Practice Act together, but really it flows really well. And from my perspective, when I think about doing a PT evaluation, I walk in with a patient and they've got shoulder pain, and the evaluation from the doctor says shoulder pain. I perform a number of special tests, and I check their range of motion. I'm checking their manual muscle testing. I'm seeing if they've got impingement. I'm going to see if they've got any instability or relax. I'm checking all of these things, screening a labrum, and then I look at the sensitivity and specificity of those special tests I'm using. And we've kind of had this conversation before. It's really low. It's not great. Yeah. And so I remember I got out of physical therapy school, or actually being in physical therapy school, and going, man, the sensitivity, specificity is crud. That's terrible. For a lot of our special tests, what should I do with this? Well, maybe if I just do like 50,000 special tests for each shoulder patient, I can kind of get this clinical picture that really helps me, right?
Right.
That's what I've always done. And I can kind of tell you how we started in musculoskeletal ultrasound, but I bring that up because really, when we compare the sensitivity, specificity of musculoskeletal ultrasound as compared to like an MRI, it's pretty strong. MRI is the gold standard, right? But it kind of varies by joint, and obviously I can't get deep to like the ACL very well with musculoskeletal ultrasound at the knee, but I can see a lot of structures. I can see the meniscus, I can see all these, and certainly have great views of the rotator cuff of the shoulder, all of the ligaments of the ankle, et cetera, et cetera. So when we talk about the utilization of musculoskeletal ultrasound in the PT practice, I think of it as just that extra extension in my mind of what I'm using in my clinical exam. It's just another special test for me.
Right.
Only it's a very diagnostic special test with great correlation, great reliability. I can do it time and time and time again. And I can show the patient even in a sequential way that by repeating this every 4 to 6 weeks, depending on the problem, that we're actually improving beyond did their strength improve? Can they sleep better at night? Did this special test improve slightly? Is their manual muscle testing up a half grade? Like, we can really look at the tissues and get to the base of their pain and see improvement. It's phenomenal. It's really,
I really think, and unfortunately, I've been saying this for about 5 years and it hasn't come to fruition yet, but I think in the next decade, ultrasound should be, and I'm hoping that it is, like dry needling is now. Like, you and I have been practicing probably about the same amount of years, but 10, 15 years ago, dry needling was quite sure what it was, right? It was way out there, right?
Yeah.
And I think ultrasound should be even a greater tool diagnostically and could have a greater impact on our plans of care than dry needling is. And is something that I think a lot of physical therapists should embrace, to the point where I wish the APTA would do more supporting diagnostic ultrasound and pushing it more. I don't know about you, but this last month's APTA magazine had a long article about states across the country that had grassroots efforts to allow physical therapists to refer for x-rays. Right. No mention in there whatsoever that we can do diagnostic ultrasound. And I sent a letter to the editor. It just kind of pissed me off, frankly. There's a blind eye to it. I don't get it, to talk about all these other things that they want physical therapists to do. But if you really want to make us autonomous, if you really want to make us gatekeepers, give us push diagnostic tools that we currently have in most of our scopes of practice. We're talking about musculoskeletal ultrasound today, but also EMG, nerve conduction studies, which are also within our practice, within our scope, mostly throughout the country. Like, why aren't we pushing these things? It just drives me nuts.
It is a little bit of a head scratcher, I'm going to say. And I think for the most part, as I've kind of talked to therapists and those that haven't jumped into it yet, it's just a lack of maybe feeling comfortable with something they haven't done before. But how many times in physical therapy do we come across something we haven't done before? I mean, if you would have told me a few years ago that I'd be strapping some blood pressure cuffish and trying to do blood flow restriction while I was rehabbing an ACL or patellofemoral pain, or even up at the rotator flow, I would have been like, why would that even help? That doesn't make any sense to me. And now the research comes out and shoves this in a completely different direction. And you see this, it just ignites like wildfire. People see the research and therapists are all over it. So part of it, I think, is really like getting on and talking about what we're doing here today and trying to get out in front of the crowd and talk about, hey, there's wonderful research in musculoskeletal ultrasound, and we can do it.
Yeah,
it's got a learning curve. We're not going to say that, right? Because if you could just pick this up on an evening,
no, you can't get it on a weekend course.
Can't get the weekend course to do it, and to be able to pull a mentor in is really helpful. Let me tell you a quick story, Nathan, because I think for us and for our practice, this will kind of show a little bit how I got interested in this, and then kind of steps that were made, and hopefully, if there's any PTs out there, practice owners that have considered this, but have just not known like where to go or if it's worth it, this is a great conversation to have. So I would say about now 10 years ago, maybe 9 years ago, there was a sports med doc in town. He's phenomenal at musculoskeletal ultrasound. Like, honestly, within our practice, we call this doctor the wizard, because the things that he's been able to pull off on ultrasound that were perhaps not visualized on MRI, got to the root of the problem. We've always just had an incredible amount of respect for him. And one time he sends me this patient. This is kind of a story that I've told in our practice for a while, because I get the same question. Why do we do this again? Especially with anybody that's new that's coming in. He sent me a patient that was an engineer by day and a drummer by night. And, the right arm, that dominant arm, is up on that ride cymbal, and just a lot of pain. And And he had done an ultrasound and said, hey, look, we really don't have anterior impingement going on, no subacromial impingement. He's measured the space. There was a great gap there, or enough spacing between the humeral head and that and the acromion. Right. And he said, but the supraspinatus was measuring in at like, boy, what did he say? I think at the time, this is a few years back, so I think it was like 1.0. So he's like, it's thick. It should be 0.5 and it's 1.0.
Okay.
And I said, okay, so it's twice as thick as it should be. And he's like, yeah, that's why it causes pain. Like if you think about swelling of the rotator cuff for whatever reason, and this, he said, this is not just your acute tendonitis. This is a tendinosis. This patient has had these symptoms for greater than 6 months. And finally, I said, well, how would you define that? He says, actually, greater than 6 weeks is often getting to that tendinosis stage. So he said, here's the symptoms. It's thickened. I can see it on the ultrasound. It has good bony spacing. I don't want to have to do surgery. I don't want to have to do a subacromial decompression, even though I know
there's nothing to decompress.
Yeah, I mean, really,
right.
You can give it more space, but it's that it's swollen that is the problem, and it's causing all mechanical difficulties and pain. And then he said, oh, and by the way, there's positive finding for color Doppler. And I said, I don't know what that means. What does color Doppler mean? He said, oh, it's a setting on the ultrasound machine where I've got an ultrasound right here, but as I'm putting this probe on the patient's shoulder and it's showing up on the screen, I can hit the Doppler, and what it's going to do is it's going to give me an idea for blood flow. Now, if I put it directly over a vessel, it'll show you that artery or vein just pulsating through, right? And we often think of color Doppler when we're maybe screening in the ER for DPT or something like that.
Right.
So same technology, but instead we're going to put it over that thickened rotator cuff. And not only are we going to see even without color Doppler on the screen that it's thickened, that it doesn't have the same what we would call echo texture. It really looks rough, basically, without using some of the terminology that we learn as PTs when we start to go the ultrasound route. We'll just say it has poor echo texture. It's non-fibular echo texture, but really it just looks rough, right? And it's thick and it's swollen. And then you put this color Doppler on there, and it starts to show up and kind of pulsate with these, what it looks to be little sparkly color Doppler findings throughout or at the base of the tendon. And the doc said to me, it's got hyperangiogenesis. Look that up. And I said, hyperangiogenesis with tendinosis? What does that mean? And I had to actually go do some reading to find out that as tendinosis at any tendon progresses and becomes more chronic, what the body tries to do for some reason is put more capillary beds into this tendinotic hyperinflammatory structure. Yeah. It doesn't help it. And of course, as we have this broken inflammatory cycle at times with chronic inflammation within the body does lots of things that really doesn't help it to heal. And it becomes kind of stuck in that inflammatory cycle. So I talked to the doc. We started treating the patient. We started out with some A-stem, some people doing grafting, but anyway, we started some of that. And we did some real light. We didn't do super heavy, even though I kind of pushed the doc. I said, by Kerwin and Stanish from some Canadian docs from 1978, if I'm quoting that correctly, they said, hey, eccentrics are the bomb for tendinosis. Right. And hey, if you are going to treat with just eccentrics alone for 3 months, you're going to hit this thing out of the park. And he said, no, I want you to go lighter. Let's let the ultrasound guide our plan of care. I said, all right, let's do it. So we started we're doing some A-stem, we're doing some range, we're doing some gentle activation, not really heavy, a little bit of eccentrics, because I really believe that's where the research at the time was driving me, and some modalities, whatever, right? So the patient's coming in, and 4 weeks afterwards, he goes, hey, let's do another follow-up ultrasound. So he's taking a picture of the exact same part of the supraspinatus, pulls it up on the screen, and goes, this is great. Bart, you went from 1.0 down to about 0.06, right? We're not quite back to normal, but it's looking great. Now it's super weak still, so we need to start into what you were pushing me to do before. Let's get the concentrics, slow concentrics, heavy eccentrics. Let's get some of those things going, and let's see how it performs. Well, the interesting thing to me is I went back and I looked at my daily notes and my progress note to the doc after everything was done on this. The only signs physically or clinically that I could see with the patient outside of what he was guiding me with ultrasound that was really telling me if I was going the right direction. As the patient had told me flat out, I am sleeping better at night. And you hear that from your shoulder patients, right?
Sure.
As you start to see that progress, they're like, hey, Bart, I'm sleeping better at night. This is great. They're totally thrilled. But they hadn't been able to do any drumming at night. And we had to do some ergonomic changes with their desk so they weren't elevating the shoulder. And we made some of those changes. And so they said, even during the day, it's feeling better at work, as in my engineering projects I got going at work. So I am thinking we're just hitting this out of the park. The doc shows me that the thickness of the tendon is reducing towards normal. Yeah. We start our strengthening. He does another 4-week follow-up. We went back and we doubled it in another 4 weeks. I was so disappointed.
Like
so it was clinical findings. Yeah. 8 weeks from the beginning of PT.
Oh, no.
4 weeks, we showed that we were making tremendous progress. In fact, the hyperangiogenesis, that color Doppler that we talked about, had totally been cleared at 4 weeks, and the thickness of the tendon had gone down. But when we went to strengthening, for some reason for this patient, against all research that was telling me that eccentrics were good, that what I was doing was the right thing, the symptoms were coming back. The thickness of the tendon was coming back. So then I go right back to the patient, because my gut is that I'm getting some non-compliance here, right? I'm like, no way, because the research, we want to be evidence-based. We want to be research-based. Right. I wasn't getting what I thought I should get. And the doc said, I had a conversation where I just said, I don't know if we're back to drumming at night and we're just not talking to me about it, but to double that, I just don't feel like, from what the research is showing us, that's what's happening. And the doc said, all right, we're going to go ahead and do a subacromial decompression. Sorry. Whether it's compliance, whether it's intervention, that's evidence. Really, if we want to talk about evidence-based practice,
right?
This was giving me evidence,
right? Not
just research-based, but with this individual patient.
Yeah, and maybe not the evidence that you were hoping to get.
No, I was so mad, right? I was so mad. So I walked with, patient came back after surgery, totally resolved. The doc did a couple follow-up ultrasounds on it just to look at what was going on. It resolved really, really well, right? Mm-hmm. But in my mind, if I had controlled all variables, I should have been able to hit this out of the park.
Right.
And yet, even before symptoms were changing dramatically, the tissue told a different story.
Yeah.
And so I talked to the doc after this case, and I said, okay, this musculoskeletal ultrasound is phenomenal. I thought we just use this on babies, in utero.
Right.
What is this, and how do I get a hold of it in the PT practice? And he goes, well, I've been doing it for a few years. It takes a lot of work, to get good at it and to be able to understand what you're doing. You ought to have a really good training course. You ought to have a mentor. That was at the basis of his first discussion. And he even said, I don't know if I really want PTs doing this, but it's probably within your scope, really. I'd love it if all PTs in our area just sent all this to me, but he's got like a 4-month waiting list. I don't know why. Right. And so we just hunted this down. We went after it. Right. Cool. And that story has repeated itself, whether it's an ankle, whether it's a shoulder, whether it's a hip. And in fact, it becomes much more, the depth of what we find is tremendous, because I'm sure you've treated that patient before, Nathan, where they come into your practice and they're like, yeah, I felt this pop at my shoulder. Man, I went into the GP and they said, I got to have failed PT before they're going to do an MRI.
Yeah.
And so I get this script and it says, PT, evaluate and treat shoulder pain for failed PT. Like the doctor's telling me that they're sending them for failed PT. And I'm like, oh my goodness, what? And I don't know what that makes us look like as a profession, but it's not good. Right.
Yeah, exactly. So are you using an ultrasound a large number of your initial evaluations, it sounds like, then?
I would say especially peripheral joint. Now, obviously, if I've got spine issues, I tend to use EMG, right? And that's probably a discussion for another day. But a large majority of all of our peripheral joints that are coming in,
nice.
I mean, unless they had an MRI 4 days ago, right?
Right. I mean, why wouldn't you? Because I'm sure you're going into it now, comparing what you're doing now in an initial evaluation with the use of a musculoskeletal ultrasound versus what you were doing 10 years ago with a bunch of specific special tests that really don't tell you a whole lot, right? Your plans of care are different, I'm assuming, as you're seeing some of these people, or they're just varied somewhat. I'm assuming it's changed not only your initial evaluation, but also the plan of cares you're developing.
And there was a multi-center study that looked at this, that I don't know if can I quote this? I think I can quote it at this point. It's coming out. It's going to be published, I think, in the next few months here. But it looked at the utilization of musculoskeletal ultrasound in the hands of the PT and asked questions like, well, how confident was the patient in their plan of care after ultrasound as compared to before ultrasound was used for their shoulder or knee or hip, right? And that was a dramatic change, up 95% plus. Wow. We very much felt like as a patient, they understood what was going on. There was something very objective about what that presentation gives to the patient.
Right.
But then the next question, and hopefully Dr. Watt doesn't kill me for throwing this out here, but it'll be published here, I think, soon. Greater than 60% of the time, the PTs were changing their plan of care. And I don't get that out of any individual special test, right? And not even all the time. Don't get me wrong. I'm not throwing out my clinical exam. Sure. Not by any stretch of the imagination. This is really just an extension of that clinical exam.
Right.
But when I can look at that, say, for instance, this is probably one of the things that we see most often. Do we have, let's go back to that shoulder presentation for a minute. You're seeing that shoulder, Nathan, and they have maybe 75% active range of motion, but painful. Maybe they had some trauma associated with it. Maybe it was kind of gradual, and then maybe some kind of reoccurrence of something. Anyway, and it's weak. It's 3+ out of 5 in so many directions, right? And all special tests are positive, right? I mean, at least all impingement tests are positive because they're so non-specific for a specific. Anyway,
right.
And I'm left to wonder. I have a negative drop on. So I don't think they have a full thickness rotator cuff tear, maybe. But they got a big deltoid. Like, I've had some weightlifters come in from our clinic that's right next to a gym, and they come in and they power through that. They give me full active range of motion, and they've got a full thickness rotator cuff tear, right? It's not always the most active. So I throw that ultrasound on there, and in one patient that comes in with a similar presentation, I go, oh, you've got a partial thickness rotator cuff tear. Well, how does that change my plan of care compared to the one we talked about earlier, where it was just a tendinosis?
Right.
I could load up and do a lot of slow, heavy concentrics, slow, heavy eccentrics with that patient that has tendinosis. But I might not want to do heavy loading on a partial thickness tear and then just finish it off.
Yeah. Well, yeah, and that's the thing is we're going in there blind. I mean, we think these special tests are the bomb, but they're not. And we're going in there completely blind. We don't know if there's maybe a bone spur. We don't know how thick the tear is. We don't know exactly what we're dealing with. We don't know if it's abnormally thickened. We're going in there guessing. I mean, we're like throwing stones, essentially, or throwing darts blindly. Just like, okay, I guess we'll try this, see if it works. Right.
Well,
but we have the tools at our disposal.
And they're there. The struggle is, I think if you were to ask me, Nathan, hey, before you started musculoskeletal ultrasound and going down this road of diagnostics within the PT practice, how confident would I have been with my shoulder evaluation and being able to distinguish? I would have said, 100%, I'm really there.
Yeah, totally, right?
Right. But I'm going to tell you, since I started this, I just didn't know what I didn't know.
Yeah.
Right. And the research behind all of the sensitivity and specificity of our special tests shows what I don't know.
Right.
But my idea of just doing 50,000 of them to put together this clinical picture, and now I really, really know, showing with my patients as to the amount that I was getting to successful discharge that perhaps I didn't really know. You know, you get that MRI back. What a disappointment it is after spending like 4 or 6 weeks with a patient working on shoulder pain that you identified as maybe a partial thickness tear, just to find out that it was a full thickness tear and you were never going to get them there.
Yeah.
You were never going to get them there, right? It's a little bit disappointing, but it's even more disappointing after surgery. They come back to see you again and you've only got like 7 more visits in their total capped plan because you burned them all on the front end. And if you would have just known, if you would have just done the ultrasound, right?
Yeah. I like how you brought that up. There's two things that I'm taking away. Number one, they don't know what they're therapists who are just haven't exposed themselves to this possibility, this technology. They don't know what they don't know. They're watching a 19-inch color TV, with the tube, the really thick, heavy ones that we watched 20 years ago. I think this is a really cool picture. It's a really nice color picture.
And that's right. And if I bang it really hard on the side, sometimes it gets even better, right?
Yeah, right. Yeah, no problem. Then you expose them to a 60-inch flat screen, HD, and you're like, oh, I didn't even know that existed. That's a possibility, right? And so they don't know what they don't know, right? And so that makes it hard. And they also, there's that barrier of entry where it's not a weekend course. You're going to have to spend hours fine-tuning your skills, finding the tendons, knowing what the different structures look like underneath the ultrasound head, how to find them, and then have a mentor tell you, oh no, that's not a nerve, that's a tendon, or vice versa.
Right.
Like, crap, that sucked. I spent a lot of time on that. You need a mentor to show you these things, right? So I could see that being that last example being the thing that keeps this from really getting into a number of PT clinics across the country is simply the barrier of entry. It's a postgraduate course, if you will, essentially.
Absolutely. And I think, kind of back to that, we were talking about dry needling at the beginning, or maybe BFR. Those are things that have just caught on so quickly in the PT practice. And a lot of them are that weekend course, right? And it makes sense so much with what we're seeing day in and day out, and the results are phenomenal, and the research is great. So all that, and musculoskeletal ultrasound meets that same criteria for PTs, for physicians, for sports med physicians, for orthopedic surgeons. Like, it's being utilized more and more all the time,
right?
But it just has that extra barrier, like you're saying. It takes a little more work.
I love how you mentioned also the patient side of it, because my discussions with musculoskeletal ultrasound providers, and that is when the patient sees the picture and you can point it out to them, there's your issue right there. They're like, whoa, so you're going to work on that? That's exactly. It's like the engagement, the buy-in just takes it to a different level. I mean, you can do all these tests and you can say, so what I'm seeing is you've got some tendonitis. Well, they don't know what that means, but if you can show them, there's your tendonitis on that muscle right there, and here's exactly where it is and how bad it is, then they're like, I believe you now, because this is an objective thing and not you just telling me what you're thinking.
On that same subject, we were anecdotally, I know this is true, but I haven't run the numbers yet. It's on my to-do list. But I would love to separate the patients that come into our office day in and day out from post-surgical to kind of pre-surgical with musculoskeletal ultrasound imaging to pre-surgical without musculoskeletal ultrasound imaging. Because what I find is in that transition, that conversation that you just described where the patient sees it, there's a compliance level with physical therapy, both in their home exercise program and also in their visit compliance, that the pre-surgical musculoskeletal ultrasound group becomes closer to that post-op group in compliance. And you think about that and you go, why do I like to see, why am I getting excited when I see a post-op shoulder show up on my schedule tomorrow? Well, it's because I know their buy-in is huge.
Right.
Now, predictably, I can tell you exactly where they're going to be 2 weeks, 4 weeks, 6 weeks, 8 weeks, 20 weeks down the road. Like, right. It has some variability, and you want to be good at what you're doing there and protect what you need to protect and strengthen what at the right time, what you can strengthen. But really, musculoskeletal ultrasound gives you that is as far as your plan of care and what to do with when on that degree as well. But it also gives you that huge buy-in, just like that post-op patient has, where they're just like, yeah, I already invested. I already know exactly what's going on. I know I've got to go to physical therapy now. And that patient that comes in and I show them the ultrasound and they didn't have surgery. And they were kind of sitting on the fence as to, man, is PT going to get me better? Now they know. Yeah. With a greater level of confidence. PT is going to get me better.
And you're showing them 4 to 6 weeks later the difference in the tissues.
That's exactly right. I had a friend of mine from Texas. I should throw this up on the screen right now. A friend of mine that does this in Texas sent me a snapshot of a supraspinatus with a big fat bullet hole tear, partial thickness tear on the cortical side of the supraspinatus tendon, right? And we had been discussing when is the appropriate time frame that I can show the patient the level of improvement and healing of the tissue. Sure. Is it 2 weeks? Is it 4 weeks? Is it 6 weeks? And this is still, I mean, you've got normal tissue healings that have been well documented for tendons, right? And he said, this is 4 weeks out. This is 4 weeks from my initial measurement. He showed me the first one, and then he showed me the follow-up at 4 weeks. It was the bullet hole. You could still see the outline, but it's graying in with tissue. Like we're really seeing the healing occur. And it was not as large. He did some caliper measurements of the initial one, and it was shrinking like phenomenal. Cool. Yeah, really good to see.
Are you using musculoskeletal ultrasound also with your dry needling for guidance?
I do, especially, and this is going to make a lot of sense, especially for the people that do musculoskeletal ultrasound out there. But if you don't, think about like your lateral epicondylitis or tendinosis at the lateral elbow, right? A lot of times I used to think that all of those looked the same. However, some with PT never got better enough to avoid surgery and they went on to surgery, and some didn't. And I would look at, well, maybe it was chronicity. Maybe it was just total severity. Maybe it was if they were a diabetic and had comorbidities or a smoker, maybe all these things as to whether I was successful or not. And then as I started to do musculoskeletal ultrasound, I noticed that the ones that were tougher cases were ones that had an enthesophyte. In other words, kind of a bone spur that was growing back and into the tendon. And I went, oh, okay. Or another kind of sub case of that same idea, the ones that had more calcium deposit, had more calcific tendinosis. That was worse, right? Now, dry needlers out there are going, yeah, I dry needle that every day. That's great. But if you utilize your ultrasound and try to place that dry needle right at that enthesophyte, right at that, like it's freaking hard to do.
Yeah.
And certainly blind, I'm going to tell you that the research for musculoskeletal guided injections with physicians versus not using musculoskeletal ultrasound to guide just joint injections, like there's a dramatic difference.
It's huge.
Where that medicine goes.
Right.
So even though I think we're fairly good anatomists as physical therapists and probably the best out there, in my opinion, by far, you throw that flashlight exactly where that enthesophyte is sitting. And then you guide that with that musculoskeletal ultrasound, guide that pin right to that source of their pain. And then you kind of piston that guy, right? Mm-hmm. And the patient is going, oh, yeah, that's where it is. That's exactly, yep. And I'll tell you, the results are just so much better.
Really?
Yeah.
Oh, how cool, man. Wow.
So there's that aspect of it. And then, and do the same thing at the shoulders, right? Sure. But there's also some structures in the body you don't want to hit with a dry needle. They went over this in class, right? You really don't want to hit an artery. That's not a great idea. Yeah. You really don't want to purposely come up and hit a nerve, right? And so there are times where I'm in a zone where I want to know exactly where I'm at. And for the benefit and safety of the patient, that's where I'm using it. And other times where I'm trying to hit a specific target, and for the benefit of the patient, that's why I'm using it.
We're talking also about, it's not a weekend course. What was your experience much further along in musculoskeletal ultrasound training and performance than I am? How long did it take you to feel comfortable? And when I say that, I know that depends on how many tests you're doing per week. But if you're doing a steady stream of, say, let me throw a dart, 4 to 5 musculoskeletal ultrasounds a week, how long do you feel like it took for you to be really comfortable with your skills?
And I actually, you bring that up as that 4 to 5 a week. That is really where our practice has found that sweet spot of.
Is it?
Yeah. You got to be doing 4 to 5 of these a week to become competent, to become comfortable. Now, when you talk about that level of competency during what I'm going to say is this phase 1 learning period, that's the key of having a good mentor, right? Yeah. Because using this diagnostic tool is one thing, but if you don't use it properly or don't interpret it well, then your credibility just goes down the toilet.
Right.
Right. You're going to send something over saying, hey, Dr. Shields, I think that this patient you sent over has a full thickness rotator cuff tear, and lo and behold, they do an MRI and they don't. Well, that's not good, right? You can't have that. Yeah. So, getting into that phase 1, and if you're doing 4 to 5 of these a week, it's going to take you about 6 months.
Okay.
To become really comfortable with what you're seeing. Really, it'll take you about 2 months if you're really working hard and doing a lot of studying, have the proper learning materials behind probe placement, image capture, image interpretation, and all of those. It'd take you a couple months just to be able to say, what should normals look like?
Yeah.
And then probably another 4 or 5 months after that, well, at least 4, to where if you're doing that kind of volume, then pathology really starts making sense. And then from there, it's almost like a bottomless pit of learning. In other words, like sometimes I think in our careers, and I don't know if you've ever felt this way, Nathan, you got out into the PT world a couple of years in, you felt like you were no longer a staff PT. You really kind of had a grip on maybe on 70, 80% of what you were seeing every day. But there's still 20% out there that, I want some more. And then you got maybe to year 5 and you're like, oh, I really feel like if I was coming to see me at year 5, I'd rather see me at year 5 than certainly me at year 1.
Yeah.
Much more competent as a practitioner.
Right.
And you kind of get that same scenario to a certain degree with ultrasound, except for because of that mentorship where somebody that really has had some good years of experience is kind of helping you to make sure you're not miscalling things.
Right.
You have a safety net where you're not just shooting in the dark, hoping you're right, basing plan of care, medical costs, direction of patient back to physician to surgeon to whatever.
Right.
You can't be doing that. And so really there's what I would say phase 1, if you're really working hard at it, can be accomplished within 6 months. It can be done well with a mentor, and it can be for the benefit of the patient and in that area of do no harm, right?
Yeah.
We don't want to do any harm.
Yeah, and I think I had the same time frames. The one thing that varies between EMGs and ultrasounds, I always said, is that ultrasound has it's so much easier to implement, right? You can see it on so many of your patients, or the utilization of it in so many of your patients. You can bill for it within the scope of a day's treatment, right? If you're billing 4 units, it can be one of the 4 units, an ultrasound bill or a code, right? In that respect, it's much easier to implement into a practice in general. You get the picture, there's no harm, it's just the ultrasound, right? A couple of months, you can feel relatively confident, especially if you have some mentorship to guide you. 6 months, you should be doing pretty well at what you're seeing. And then in total, in order to get your certification, just give the listeners some guidelines. What does it take for you to, number 1, sit for the certification exam? What are the other things? What do you have to have done in order to sit for the certification exam? And what do you get?
Yeah. So that's a great question. So there are 2 types of board certification, so to speak, available to physical therapists interested in musculoskeletal ultrasound. The first one is an APTA fellowship. And it's a fellowship of musculoskeletal ultrasound, or FMSK. And it really, you have a certain amount of studies that you have to do. You have both a certain amount of courses that you have to take, and then you have to pass both a written and a hands-on exam, right? Practical exam. And then the other certification that's available is available through POCUS. It's a
point of care ultrasound.
Yes, point of care ultrasound, and it's RMSK. Yeah, RMSK is a registered musculoskeletal, specialist at that point, and RMSK is recognized for physical therapists, for physicians, for your nurse practitioners. It kind of hits the whole gamut.
Right.
I think there's value actually to both.
Yeah.
But I was really excited that the APTA supported and authorized a fellowship in musculoskeletal ultrasound for physical therapists, because there's groups out there that are non-PT based, like AIUM, that recognize physical therapists as a musculoskeletal provider. There's POCUS that pulls us in as point of care ultrasound providers, and it was great for the APTA to be able to say, yes, physical therapists can and should do this, and we've got a fellowship that supports that.
That's cool. Some cost to it, like the unit you have is Sonosite, I'm assuming, behind you, right?
Yes. Yep.
And that's what is it nowadays? Like $8,000-$10,000 more?
Yes. Yeah. So the nice thing is the longer we go down this road, the more competition there is for equipment, the more cost effective it becomes.
Sure.
So there's some great equipment out there. We use a lot of Sonosite brand ultrasound equipment. There's Esote. If I'm saying that even correctly, it's an Italian.
ESOTE or something like that.
Yes. And we've got one of their machines that actually is by far like the Cadillac. As we're talking about this, it's just that image quality that just improves and improves at each level. Honestly, if we had a practitioner out there that was interested in talking about how to get in on the ground floor on a little bit more of a cost-effective way, there's a few groups out there. I went through HODS, hands-on diagnostics in New York for my training. There's ways within HODS to be more cost-effective, depending on if you're looking for EMG and ultrasound, just ultrasound, whatever. There's options out there. Right. There's a few other groups out there that do some of the training. And then as far as equipment goes, well, there's new equipment, then there's used equipment. There's some good things you can do to make these things available from the ground up to make it a little bit more cost-effective than just swallowing a bunch of debt, which none of us do.
Some of I think it's called the Butterfly, right? The handheld ones that you can plug into an iPad or your phone or something like that.
Yeah, Philips has one. Yeah.
Yeah, isn't that like a couple $1,000s maybe?
Yes.
And then you got but the image quality might not be as good, right?
Yes.
And then and
I'm kind of an image quality snob now. So the more you get into it, the more you're like, oh, no, I want to see that with greater quality. So we started with a Lumify, which was one that connected up to an iPad, and but you couldn't do neural ultrasound if you're looking at the carpal tunnel and measuring, and at least at that time. Now I'm saying that I'm dating myself because that was a few years ago we were doing that, and somebody from Lumify is going to be listening to me saying, "Oh, we've corrected that. We got great calipers for measuring this." So you don't take that as the gospel truth here. Do your research, but there are a lot of options now. Where 7 years ago when we first started this, Nathan, there wasn't a lot of options.
It was kind of Sonosite, and that's it. You either got the $10,000 one, which was the basement model price, or you got the $60,000 Cadillac. It was beautiful and almost took the tests for you. Yeah. But now they're much more affordable, but like you get what you pay for essentially. Yeah. So someone who's interested in this is gonna have to pay for the equipment. It's gonna be a few $1,000s spent at least. You're gonna also pay for the training. And what I would recommend, and I'm sure you would as well, any training would be great as long as there's additional follow-up mentorship after the fact. I mean, having that mentor is almost a must. Whether that could be someone who's part of the training organization. It could be a physician, right? I've got a friend in New Mexico that's doing this, and he's got a physician friend that is kind of checking his studies and making sure they're right,
Absolutely. There's a lot of ways to get to that, but I think you're right. Mentorship is key. And there's still times, Dr. Mohini Rawat, PT out of New York and works with HODS and has been my mentor for a number of years. And I just sent her, I've been doing this for 7 years. I saw something interesting at a meniscus the other day and shot her a few snapshots and said, Mohini, I'm thinking this is this. Am I right? Right. And you just like that level of confidence, right? Because you need it.
Right. I know it differs state to state, and it differs depending upon your Medicare intermediary, from what we're finding out, whether or not Medicare reimburses for it or not. Right. I know when I started doing ultrasound in Arizona, my initial claims sent to Blue Cross Blue Shield were denied. I don't remember what the reason was for denial, but what I had to do was appeal it, and also I got a letter from the State Board of Physical Therapy saying that ultrasound was within our scope of practice. And based on that appeal with the letter from the Arizona State Board of Physical Therapy, agreed and then paid for the claims after all. I had to do the same thing here in Alaska with EMG and ultrasounds. And so now I'm getting paid for those here. And depending on the state, you can get reimbursement for ultrasound. But it also depends on the insurance company. It depends on your Medicare intermediary. But I know in Arizona, we would get anywhere from, say, $40 an ultrasound to up to $200 an ultrasound outside of your flat rate payers, which is an issue, a separate issue. Flat rate payers are going to pay you flat rate, whatever you do. Does that sound about right? Is that where you're landing with your range of reimbursements?
Yeah. The last time that we looked at kind of per ultrasound reimbursement, we were hanging right around in 115 per ultrasound across all payers, right? And that's including some where we're not getting paid anything, and some that we're getting paid quite well. And so that's kind of been our budget on how we look at things.
And that's where I would really hope and wish, and maybe we can do this because you're part of the network with Hands-On Diagnostics as I am, that we can work together and really push Medicare to recognize physical therapists as providers of musculoskeletal ultrasound and how it benefits our care that we provide, right? And how it lessens the overall cost if we can be more certain about what we're actually treating.
Absolutely. We had that discussion with a payer group about 4 weeks ago, and the auditor reviewer basically called us up and said, I don't think that physical therapists should be doing this. I think this should only be a radiologist. And we said, well, how come you think that? And she said, well, it's not like I'm a practitioner. I'm not a provider. It's because under the classification here, this comes under, for our insurance company, a radiology code. So I assume that since in our classification for our insurance company, it comes under a radiology code, only radiologists should be doing this. We said, oh, okay, can we tell you how we use it in our practice? Show you some research on how this has been used in different states as well as in the military.
OBGYN settings.
Money.
Yeah.
and it was so fun. I mean, because by the end of the conversation, this individual that initially had a fixed idea that physical therapists should not be doing something with this code, at the end said, boy, you guys have totally changed my mind. It's saving patients money. It's going to save our insurance company money. It's saving the patients time. It's saving them lost time off work. Like if we really know by screening and doing a musculoskeletal ultrasound on a shoulder, a knee, or a hip, so that we're not doing blind PT and waiting for an MRI after we've failed at PT. Like back to that idea of the order for failed PT. Like,
right. Or it's cheaper than an MRI.
Yes.
Right?
Yes.
There's that too.
Much. Yeah. So she at the end just flipped and said, you know what? I'm going to take this back. I'd really like you guys to write a paper for this, kind of give me a kind of like an essay, all of your bibliography and just anything that you can from military and everything you've talked about, the different studies that you've brought out and why this is cost effective in the hands of the PT. And I'm going to go back to the board and I'm going to fight for this because this is in the best patient interest.
Yeah.
So
that's great, man. Well, good luck with that. Because people who are listening, number one, they might want to see where their state lands on this with the State Practice Act. But they also have to recognize that as they're moving forward and doing things that are outside the normal, well, consider our route to doing dry needling. Right? We had a little bit of resistance to doing dry needling, if you do say so, looking back on our history. We're probably going to meet up with some of the same resistance with musculoskeletal ultrasound. People are going to say, you can't play in this sandbox. They're doing it with us with EMGs. Should be almost expected at this point by physical therapists to expand what we can do underneath our scope and actually live within our scope. To be expected, but there's huge benefits to what it can do for our profession. You're seeing it in your clinics, a great revenue add for you. I know you tied it into what you're talking about in your book, Debt Free PT, how you can incentivize your teams and pay back student loans based on what they're doing with musculoskeletal ultrasound and incentivize them in that way. It's been a huge boon to your practice. And so that's why I loved having you on today.
Well, it has. And I appreciate being able to just talk about it. Obviously, we could just keep going for a few hours because this is my favorite, at least one of my favorite topics. And I think we've hopefully hit on some of the questions and answers from some of the practice owners, PTs out there that are kind of thinking, well, how do I get into this? How do I put my foot in the water, kind of my toe in the water and see how this works? You're a pioneer. I think you've kind of said that well, Nathan. I mean, there is going to be a little bit of resistance from a handful of people that always want to say, well, you can't do that. When in reality, a Practice Act supports it and everything that you're doing with a mentorship and with a fellowship and being truly trained and passing that certification exam.
Hey.
It's like anything else. It's like somebody telling you can't become OCS certified. You shouldn't do it.
Yeah.
SCS, you shouldn't be on a sideline because there's other practitioners that are there. Well, right. You're always going to have your naysayers or whatever, but we've always seen physical therapists rise above, obviously within our scope, and be able to perform. And why? Yeah, there's this idea that as a profession, we need to be able to grow, and we need to be able to be paid well for what we do, because we have a tremendous impact. Right. But we also need to recognize that to get to some of those milestones as a profession, we're going to be uncomfortable. We're going to search and we're going to have to push ourselves to learn at night and study a little bit more, and not just put the books away at graduation and never open them up again, but be continually ready to learn and grow. Yeah.
Well, you use the right word. There's got to be pioneers, right? Strike out and are the first to do these things. And there's a number of them within the physical therapy industry already. I think that we just need more grassroots efforts and numbers to really get our voice heard. Yeah.
If we even look within the APTA today, there's a couple of special interest groups, one within the clinical electrodiagnostics wound care, right? And there's a special interest group in neural musculoskeletal ultrasound. And then there's also another one that is kind of that subset of imaging out of the orthopedics section. And there's a couple guys in there that are I think it's maybe the vice president. He's phenomenal at musculoskeletal. And I think the president, I was reading some of their bios. They've done amazing things and spent their time and their practice in diagnostic ultrasound. So I think we've got some leadership that's going that way. The more physical therapists that kind of open their eyes to that, to what's the potential in this? What can we really do for our practice and for our patients? Really, we're going to see this be the norm 10 years from now. I think we'll see that as in all orthopedic outpatient.
I hope so. Well, if people want to get to you, reach out to you, talk to you, not only about musculoskeletal ultrasound, but also your debt-free PT book, if they wanted to look into that, how do they get a hold of you?
You bet. A couple of ways. So my email address is Bart M, as in Bart McDonald. So bartmpt@gmail.com. And you can always shoot me an email and just ask questions. I usually am about a 3-day lag. I'm trying to keep up with my email. So I usually within about 3 to 5 days, I'll get back to you. We'll get something set up. And really even my cell phone number, I don't answer it during the day, but if you want to shoot me even a call or a text, I'll throw that out there. Like, we might get bombarded this way, but I'll try to get back to you that one. And my cell phone number is 208-705-4678. And just leave me a message. We'll try to get you to the right place. I'm so excited where our profession is going. Yeah. And especially at a time, Nathan, where I think we have a lot of doomsdayers, naysayers out there that decreased reimbursement. I don't know where the future of PT. Well, the future of PT is now. It's here. And a big part of it is in diagnostics.
I believe it. Yeah. And if people want to read your book, do you have a landing page for your book?
Yes, it's www.debt-freept.com. Yeah.
Debt-freept.com. Good book. I love it. All right. Thanks for your time, Bart. I really appreciate it.
Yeah. Hey, thanks, Nathan. We'll talk to you later.
Take care.
Bye.